next lecture or the experience shared by Dr. Rajesh Sinha, creating a new standard in advanced monofocal technology with ICRL Cert Toric, expert's view.
Thank you, ma'am. Very good afternoon to all of you. I'll be talking about advancement in monofocal technology. Well, IOL has evolved quite a lot. It was long back, I don't have any financial interest before I start, I must say that. Long back in 1949, when Harold Ridley first described the first IOL, it was quite primitive at that time, and the idea was just to replace something in place of the crystalline lens that was removed. And things have evolved over time, not only in the subject of the material of IOL, but also in terms of the injector systems, implantation systems, delivery system, and that is how things started evolving. And in the mid-70s, what happened that the target was to achieve an IOL, to put an IOL in place, and in 80s, the target was to have a 6/6 vision. Then what happened that people started asking that if I have put the IOL, why to use spectacles? And then came the concept of multifocal IOLs, and then multifocal IOLs had its own problems because of the diffractive steps, as Dr. Rajendra Prasad was just now mentioning, and glare and halos. And there are certain conditions wherein you can't place the multifocal IOLs, like diabetic retinopathy or somebody who is very sensitive to glare and halos. And in such cases, monofocal lenses are very good. And if there is a monofocal lens which has some degree of increase in defocus, then that will provide a reasonable intermediate vision with, and when you implant it in both the eyes, it will work good, and it will have a good intermediate vision, and a little bit of near management can also be done by taking the object a little away, and you can manage. Now, intermediate vision has become very important these days because of the use of laptops. Right now, I'm using the laptop, looking at it, and the intermediate vision is only working. So that is one of the most important reasons why over the last couple of decades, the concept of increasing depth of focus of IOL and in having better intermediate vision has come into play, and people like to do that. But then by doing all those combinations, because the initial EDOF lenses, when it came with some rings, and those rings had some problems. And then again, people started telling that why to use these if we have those diffractive rings or the rings which are creating glare and halos, why not put a trifocal lens or a multifocal lens in the eye? Why to put this lens? And that is how people started thinking of improving the depth of focus by having advanced monofocal IOL. And in the same direction, this is a good Make in India material, that is ICRL Cert, which is a hydrophobic acrylic material, and it has a nice square edge on all sides, and 6mm lens with 13mm overall diameter, and it provides a reasonably good vision. It has a unique zonal asymmetric power distribution. Now, this kind of a picture doesn't mean that it has steps or anything. It is just the distribution of power. So zone 1 and 3 having higher power to provide distance to intermediate vision. Zone 2 and 5 having minimal power to provide the distance vision. And then similarly, zone 4 contains the nominal and higher power at 60 degrees intervals to balance the energy in photopic and scotopic light conditions. So it is distributed in such a way that the power is distributed and it's not the step. So that is how it provides some depth of focus without causing any photic phenomenon, without causing any, and most of the photic phenomenon happen because of the splitting of light. So if there are no diffractive steps, then the splitting of light doesn't happen. And that is the advantage of this optimization of this lens. And the ICRL Cert IOL is a monofocal IOL, but it has a good depth of focus. And that is what has been shown in studies. With, as I said, 1.75 depth of field is helpful for intermediate distance range, and that is what it is provided by these ICRCert lenses. And a lot of patients do have some degree of cylinder, corneal cylinder in the eye as well. So multiple companies came up with these advanced monofocal with giving the advantage of toric. And ICRCert toric is again an Indian company, biotech, no financial interest, but this is a lens which has come up with a toric on a toric platform as well, with all these powers available. And I will just show how this lens is provided to you and how you can implant. It is a preloaded lens. That is an advantage. These days, a lot of people are going for preloaded lens because we do get complications related to loading, related to pushing it hard and causing ruptures and all that. So I'm just showing you how, from the external camera view, how it looks like. So this is the ICRCert toric injector system, and this is the tip. This is here what you do, you put some fluid here. I will show the microscope view as well. And then after that you inject viscoelastic. After injecting viscoelastic, you, on both sides, under both flanges, you just close the wings so that it folds, and then you push this posterior limb, and as you push it anteriorly, so the lens also migrates, and then after that, with the movement of this, you can implant the IOL. So the advantage is that it is a single-handed implantation. So I'll just go to the microscope view now, and this is how it looks like. So this is the ICRCert toric wherein the Callisto system is being used to provide the reference marking. This is how it looks like, and this is with your index finger you can just move and you can implant the IOL. And these are the two posterior limbs which are pushed. So first you inject fluid from behind, and as well as you want to replace all the air, so you also fill it from posterior part, and then you push the IOL a little bit so that it fixes, it engages, because after that you inject viscoelastic. Otherwise, if you don't engage it and inject viscoelastic, it may get displaced. So that is the advantage. And then you inject viscoelastic on both sides, then you close the wings, and then, as I told you, you push this posterior plunger so that it pushes the lens to a position from where it can be implanted. So as it is pushed, you can see here the movement of the IOL, and the IOL has come just behind the tip of this cartridge. And then you, with movement of single finger, you can implant it. And the advantage is that with a 2.2 millimeter incision, you can inject it, you can put the tip of the cartridge inside, and it can be injected into the bag. This is how it is done, and as you just use one finger to advance the IOL, so the IOL does not move inside with a jerk. So the IOL is there inside the bag, and then it is dialed. And then, as we all do for all the toric implants, you can see these refractive zones, which sometimes you do get reflections from there, but since they are not steps, they don't cause any photic phenomenon. And then, as in any toric IOL, you remove the viscoelastic from anterior, ahead of the IOL, and from the front, as well as from behind. And then the idea is to have a perfectly aligned IOL, and this is what it is perfectly aligned on this, on the desired axis. This is one study that we have just started at our center, that is on ICRCert toric study, wherein we are comparing two groups of IOLs, two types of IOLs. One is the ICRCert toric, and the other one is iHance toric. And we want to see the visual performance as well as the advantages of implantation, because both are on preloaded platforms. So the advantage is that you would like to know that what is the exact difference between the two platforms. And the primary endpoint will be the visual acuity, and the secondary endpoints are all these rotational stability as well as manifest refraction and the ease of implantation. And patients will be those patients who have senile cataract, don't have any other pathology, they will be included in the study. Bilateral cataract, because you want to, we would also do the stereopsis, which has not been mentioned here, but we are planning to do stereopsis as well in this eye, in these cases. And those who have some systemic disease or some ocular pathologies, severe diabetic retinopathy or some corneal pathology, etc., will be excluded from the study. Now, what we found out that both the systems, Eye-Hands Toric as well as ICRL Toric, are both preloaded. But ICRL Toric injector system can implant the IOL through a 2.2 millimeter incision. You don't have to enlarge the incision. Fill the chamber with high viscosity viscoelastic. Your tip of the cartridge will go inside, and as I had shown in the video, and it goes through a 2.2 millimeter incision. But with the Eye-Hands Toric system, you require 2.4 millimeter incision for the implantation. The second thing is that it is a single-handed implantation. So you can demonstrate, it doesn't roll, because Eye-Hands Toric has a screw system. So once you take it inside and screw it, it rolls, the eyeball rolls. But here, you can stabilize with the second hand, and with a single finger, you can rotate, you can push the IOL into the anterior chamber. So that is how there is a greater ease of implantation. We did some visual parameters also, and this is just a week only that we have just done so far 12 eyes and 6 in each group. So we are planning for a bigger study for 30 eyes in each group. And so once we do that, then we will analyze the visual outcome more. But in this, we found out that there was some marginal difference between the this ICRL Toric versus Eye-Hands Toric, but this was not statistically significant, and we cannot comment on that. In summary, ICRL Toric provides continuous vision from distance to intermediate. There's minimal glare and halos. There's an extended range of vision of more than 1.75 diopter at spectacle plane, and that is an advantage. Good intermediate vision. You can implant it through 2.2 millimeter incision. Minimizes the pupil dependency because of the distribution of power. And it does provide satisfactory performance in all lighting conditions in the initial R&D studies, but we have to prove it by our own study. And it has good rotational study. So in conclusion, ICRL is a monofocal IOL with some degree of defocus curve, which if you implant in both the eyes will provide a very good intermediate vision, and to some extent near as well. And there's no photic phenomenon, as I said, because there's no splitting of light, and there are conditions wherein you can't implant a multifocal IOL, but you can implant these advanced monofocal lenses with some defocus and also covering the toricity. So it does improve the quality of life. So thank you very much for your patient listening. I would like to have feedback from the experienced surgeon sitting here.
Thank you very much, Rajesh. We nicely covered all the relevant points comprehensively. Dr. Rajendra Prasad, you have some experience with the lens. Would you like to add any expert points?
Thank you. Actually, I have used a lot of monofocal IOL. ICRL CERT is a new introduction of theirs, so I haven't used much, but
ICRL Toric has been launched here in this, in the AIOS only.
Just launched.
It has not been, it was not launched. So we just started it before it was launched.
Even ICRL CERT also, it's recently launched, so
yeah.
not much of time. We have used a lot of monofocals and toric monofocals and all.
Yeah, Rajesh, actually I use this lens even for the evaluation because our hospital is one of their evaluation center from the first day last 10 years. This is something called advanced monofocal lenses which give a very good intermediate vision. Almost around 57 centimeter it has got a good intermediate and also far intermediate. And what we evaluated, the stability of these lenses are pretty good, and the rotational stability also. What we found out that absolutely there is no rotation. Probably what I feel it is a hydrophobic lens also, and the material what they manufacture is called a Benz material, which is something unique material. None of the other companies has been manufacturing, but which is on the more on the expensive side also. But if you talk about the rotational stability and the patient satisfaction, and the price also. I think the lens to see in the coming days, because absolutely no glare and halos almost 99% of the cases, because some of the other competitors what they have created a spherical aberration in the center of the optic. Sometimes some of the patient may not be that happy because of depending upon their corneal aberrations also, but here this is the technology itself is different. Though the chances of glare and halos are going to be much less.
So Krishna
And
Prasad,
the
two
ease
questions.
of implantation is very
yeah.
good. Ease of implantation is very good, and it can go through 2.2
So
millimeters.
Krishna Prasad and Rajesh, two questions.
Sir.
Is it N6 vision at 57 that is said? 57 centimeters said to be the vision at the point at which they have good intermediate vision. Is it N6?
Bilaterally, if we implant, yes.
Okay, what is it N8 or what normally? What do you expect with at